So let's talk about hemostasis. Now, at a general level, the way the body heals itself is there's some problem that happens with the vessel. It gets sliced somehow. You get stabbed or whatever. You get a shank in prison, whatever. That vessel gets severed and the blood leaks out, right? So what's the first thing that happens to stop that? Well, the platelets come together and they stick and they form this white clot. Over top of white clot then comes the fibrin. And the fibrin is this protein that gets laid down on top of those platelets, and it traps some red blood cells inside, and eventually enough schmutz gets stuck together between the fibrin, the platelets, and the red blood cells, and some white blood cells that get stuck in there too, that the clot forms. And that fibrin clot is what prevents the body from bleeding to death. Pretty ingenious, right? So after a period of time, after the body can heal itself and put the vessel back together and all that, then clot retraction has to occur. And now the body can remove that clot and allow restoration of blood flow. That's the process. Well, the platelets are the first part that start that. And remember that the platelets start by adhering to the vessel wall through release of von Willebrand factor. Okay? So the endothelial cells here can produce von Willebrand factor, and that von Willebrand factor pulls in platelets, makes them stick to the vessel wall, and makes them stick to other platelets. All right? There's also this, the presence of these G protein coupled receptors. And those specifically are the things that adhere to the ADP molecule on the, or the ADP receptor on the platelet, and the thromboxane A2 receptor on the platelet, and to thrombin as well. Now, if you remember back in pharmacology class, you probably learned that that there are ADP receptors that we can target with Plavix, for instance. Thromboxane A2 receptors are targeted by aspirin. And so we have the ability to interfere with this platelet aggregation through different areas. Thrombin we can mess with some of the fancy cath lab drugs. Like Riapro and Integralin and things like that. The glycoprotein 2B3A inhibitors that hit the GP2B3A receptor. So that's the process when there is blood injury to the or an injury to the blood tissue. That's the intrinsic mechanism. The extrinsic happens with vascular trauma. So when there's some vessel interruption from a knife or something like that, trauma, tissue factor gets released that produces or that stimulates these platelets to stick together. And then fibrin comes and gets laid down, and the rest of the clot forms. Okay, that's just the full picture of hemostasis after vascular trauma. Remember that the platelet surface is really a scaffold. There are multiple receptors on those platelets to which different substances can adhere. And that means that the platelets can be involved in just sticking to one another, but also sticking to thrombin as well, and in turn fibrin. So remember the arachidonic acid products, those can be influenced by aspirin. They are one of the ways that platelets stick together, and we can mess with that by giving aspirin. So there's a little summary for you, but that is the platelet stuff. Platelets have a huge role in vascular events like heart attacks, strokes, vascular disease. Those kind of things are primarily platelet-driven events. And that's why we give antiplatelet drugs to prevent strokes, to prevent heart attacks, etc. Now, we also need to talk about, in addition to the antiplatelet stuff, or the platelet contributors to clotting, we need to talk about the protein contributors to clotting too. And remember, there's an extrinsic pathway and an intrinsic pathway. The extrinsic pathway starts with tissue trauma, that is damage to the vessel itself from getting stabbed, for instance. And the vessel breaks open, and now tissue factor gets released that stimulates production or stimulates the activity of factor 7. It gets activated. That's what 7A is. That's factor 7 plus tissue factor becomes activated factor 7. And then calcium gets involved and produces, along with tissue factor and factor 7A, produces activated factor 10 or 10A. That is the part that we're interested in. We're interested in this factor 10 because that is the last step before this final common pathway that is common to both the extrinsic and intrinsic pathways, the activation of prothrombin. Okay? So all of that stuff I told you here is nice to know. We need to understand that calcium is involved here and that there's these active clotting proteins that get activated with calcium. That's really what you need to know. The next thing you need to know is that the final common pathway starts with activation of prothrombin. All right? The intrinsic pathway is where there's some blood trauma that happens. There's some tissue injury to the blood itself, and the blood then starts activating the clotting cascade. Okay? And so once that blood trauma occurs, it begins with factor 12 and goes through this whole process. Again, calcium plays a major role. We get down to the platelet level, and then thrombin gets involved, and guess what happens here? Now we're back down to the common active pathway of prothrombin mixing with all the other things plus calcium to make thrombin. So this is really what you need to know. It's nice to know the extrinsic pathway. It's nice to know the intrinsic pathway. But at the end of the day, coagulation happens in this final common pathway where prothrombin prothrombin enters and gets activated by calcium to produce thrombin. Then fibrinogen gets turned into fibrin monomers, and those fibrin monomers get laid down in the clot when calcium is present. And those fibrin fibers pull in more platelets and more red blood cells, and that cross-linking of the fibrin fibers is what makes the blood clot. Okay? That's how it works. That's how it works. If we want to measure the intrinsic clotting capacity, we measure the prothrombin time, or the PT. All right, this is the one that we measure for warfarin, because warfarin uses or activates the deactivates the intrinsic pathway. Okay, the extrinsic pathway we measure by looking at the PTT measurement. Okay, that's the extrinsic portion that that we're interested in looking at here. Now, if there weren't checks and balances in place, the clot formation would go uncontrolled, right? Well, that is what we see in conditions such as DIC. Disseminated intravascular coagulation is where the whole body freaks out and it goes way overboard in forming clot everywhere. That's bad. Well, why does that happen? It happens because there's no restraint of the clotting mechanism. So these are the restraint strategies that are used by the body. Primarily, well, I should say a very important part of that is healthy endothelium. When healthy endothelium is present, then those molecules that it produces will keep the platelets in check and keep the clotting cascade in check. Okay? So they're constant battle back and forth to maintain homeostasis. The other thing that happens is that plasmin then starts the clot lysis once the tissue has healed. And so the propagation of the clot does not continue. As the body heals, plasmin starts pulling everything apart. And that's, again, this struggle that's always going on to maintain homeostasis. The tissue factor pathway blocks extrinsic pathway activity. So that's good, right? We always want the intrinsic and extrinsic to be against each other to some extent so that there's a check and balance system. The proteases are inactivated by antithrombin. The clotting cascade cofactors are inhibited by the protein C and protein S system. That's why when there's protein C and S deficiency, it's a hypercoagulable state, right? All right, so way more information than you need to know. I just want you to have an appreciation for the fact that while the body's trying to clot, there are complementary components that are trying to prevent clot and dissolve clot in an effort to make sure that once you start clotting, your body doesn't just clot entirely. Okay? Remember, don't forget this part about healthy endothelium. It's so important. So important. And that's why ACE inhibitors work. Because ACE inhibitors promote nitric oxide and prostacyclins and all the rest of this. They promote healthy endothelial function, and that reduces risk of MI and risk of stroke. Now, we said that once the clot is formed, the body needs to get rid of it, right? Well, this is how it works. Plasminogen, and you can remember that because tissue plasminogen activator, or TPA, or urokinase, those plasminogen activators start the unclotting process.